Hello and welcome to the Chris Wolf Podcast on iCode Media. Today I had a great conversation with Dr. Roark. We talked a lot about omega-3s, specifically omega-3s in dry eye and in patients who have diabetes. Stay tuned for our future conversation in a few months related to patients with macular degeneration. I know based on the conversation I had today that that's going to be a really good one and a deep dive. So enjoy our conversation. As always, be sure to subscribe to the podcast, write a review, share it with your friends, and support those who support us. My patients with macular degeneration want clear and succinct recommendations from me related to products and solutions that can benefit their long-term ocular health and vision. To do this for my patients, I need to be confident that what I'm recommending will have a benefit to them, and that's why my supplement of choice is MacuHealth. MacuHealth is specifically formulated and clinically proven to rebuild and maximize macular pigment over a lifetime. This results in enhanced visual performance and aids in the treatment and prevention of age-related macular degeneration. I've discussed carotenoid absorption on this podcast with Dr. Nolans and Stringham, and MacuHealth uses a patented process called micromicelle technology. And this technology is clinically proven to increase carotenoid concentrations at the target tissue and deliver the highest level of bioavailability studied to date. MacuHealth has been great for my patients. We really feel like we have the ability to help those patients in all categories of macular degeneration. If you're not utilizing MacuHealth for your patients, check it out for yourself by contacting your MacuHealth representative. Emerging presbyopes and emmetropic presbyopes can be tricky. These patients want and need additional help at near, but they can be resistant to solutions that create even mild distance blur. The MyDay multifocal lens has been great for our presbyopic patients. It allows those patients to transition into a multifocal more easily and more comfortably. And we've had this lens for long enough now that we have been able to see the simple and how simple the adaptation can be when adjusting from lower ad designs to higher ad designs. When prescribing MyDay contact lenses, you can feel confident about your environmental impact because for every MyDay contact lens sold in the United States, CooperVision's partner, Plastic Blank, collects and converts an equal amount of ocean-bound plastic through their global network. MyDay multifocal contact lenses will provide your patients with a great quality of vision and comfortable lens-wearing experience, all while making a difference in our environment. So if you haven't started utilizing MyDay multifocal in your practice, I'd encourage you to reach out to your CooperVision representative to get started. Last time we talked about this, Mark, I think we were in Washington, D.C., but that might not be right. It might be that it was before that. But it had to be Washington, because I think we were down in kind of the Gaylord kind of lobby area. And one of the things that I love about you is your passion, right? I mean, I would guarantee that people that know you know your passion for something that you really believe in and embracing wholeheartedly, and it's very clear. So I would say that I don't know you that well, but I can absolutely tell your passion, and not just your passion, but like your experience in reading the literature and understanding what this means for patients. And so what I'd like for you to do is sort of break down maybe just your initial approach when you think about omega-3s. I want to try to dispel myths. I want to try to kind of wrap my mind around or help our listeners wrap their minds around, you know, the limitations of certain studies, and then also the what we can gain from those studies. So I think probably from an omega standpoint, maybe we take it a little bit higher level first and then dive deeper maybe into disease states. So tell me about just the general aspects of the benefits and how omegas make a difference in our bodies. Okay.
Yeah, good way to go. There's definitely a lot to talk about when you think about omega-3s, and I've been interested in them for a long time, and talked about them with my patients for several years now. And I think the thing that kind of led me down that path was my interest in dry eye disease that has started several years ago, and trying to understand how to help my patients sitting in my chair, understanding the best information, the best studies and research I have. And I think, when we're truly trying to help a patient sitting in front of us, there's kind of a three part. We want to practice in an evidence-based method. So we want to have the best research. We think of the hierarchical, the pyramid of evidence, if you will. We want to understand how much research is behind what we're recommending for our patients and choose the best research. And we kind of couple that with our clinical expertise and how patients respond. Every patient is unique. So there are research studies out there, but there's probably not a patient that's exactly like the patient in your chair who has, certain weight and comorbidities and maybe diabetes or maybe not, and certain signs of dryness and certain symptoms. So you have to use your expertise to kind of understand where the patient is, and then you have to think about the patient's values and preferences. So if I want a patient to take omega-3, but they're allergic to fish, or they don't have resources to purchase it, or they don't have insurance that may cover some medical testing I want to do, or they simply aren't going to be compliant. I mean, you have to communicate with your patient and figure out their values and preferences to try to come up with the best plan for them. And I think I like one of the quotes from, Hippocrates from about 2,500 years ago. And he said, if we could give every individual the right amount of nourishment and exercise, not too little and not too much, we would have found the safest way to health. So I think taking that wise quote and kind of putting it into practice, omega-3s have been around, and they were really discovered back in the 1970s. It's when this revolution of omega-3 from the work of Bang and Dyerberg back with the Greenland Eskimos, the Inuit, and they really started kind of a revolution of excitement about the potential of these omega-3s from fatty fish to have positive impacts on our health. And now we've done, 50 years of additional research. Omega-3s are the kind of tied for the 5th most published and researched molecule in history. We have somewhere around 40,000 studies on omega-3. And yet, when I say that, we still have a lot to learn. And we don't have every research study that we need, even in dealing with how to recommend patients who have these various conditions. So in my practice, I use dry eye. I use omega-3s certainly in dry eye disease. I also discuss them for my patients who have other conditions like diabetes and like macular degeneration and like glaucoma. So we actually have research in all those areas. So when you start thinking about how many patients in your practice may actually benefit from omega-3, increasing their levels of omega-3 is actually encompasses a lot of patients.
So I want to pause there because
go ahead.
You mentioned a number of things, and so let's kind of break down a few things right off the top. From a dry eye perspective, there are a number of studies that show benefit in dry eye, but it seems to me that at least to some degree, the one that kind of floats to the top is the most recent one and the largest one. And obviously, if you're thinking about the pyramid of evidence, the one that kind of falls into the most, or probably at least to my knowledge, nobody could argue with the randomization. Well, I think people try to, but unless you're going to make the case that olive oil is just as potent of a anti-inflammatory and has the same effect as omega-3s then other than that, it had good randomization, it had etc. So it's had good power to it. So the DREAM study. So the DREAM study comes out and basically says, omega-3s, no benefit. And then we can go down the AMD side, and AREDS 2 comes out. And I know you probably have similar thoughts in terms of the limitations on AREDS 2 as I do, but AREDS 2 says no omega-3s. So tell me about why did we find in the DREAM study that there was no benefit to omega-3s in patients with dry eye?
Yeah, that's a great question, and I think unfortunately the DREAM study has led some people down the wrong path. So, it was a multi-center 12-month study. Couple things. If you compare to some of the other smaller studies that had preceded it that did show benefits, there are some definitely, in my opinion, some limitations to what we could hope to gain from the DREAM study. I don't really think that olive oil, I think it was a pretty decent placebo. It was refined olive oil. I don't think that's the best explanation. Oh, there were benefits to both. And so olive oil was, the reason it was so good that it was, you couldn't show that the omega-3s were better. I don't really think that's the best explanation. The patients included in the study were moderate to severe dry eye disease patients. We don't really know, to my knowledge, whether they had meibomian glands that were working well. If you do meibography in your practice where you image the meibomian glands routinely, as I do, you'll find a lot of patients who have moderate to severe dry eye disease who are so far down the pathway that they've already lost a lot of their glands. And those patients probably require more than omega-3 to show a significant difference at that stage. So I think that's one thing. I think the other thing here.
The other thing, I'm going to pause just a second, Mark, because I want to put a finer point on that. Is, if you look at even our treatment paradigms within DEWS 2, in a number of cases, what a lot of people will do is they'll revert to kind of some of the early wheelhouse stuff in step 1 and 2, things like things like just Restasis, Xiidra, Lipoflow, Tear Care, all of those are in step 2. I believe omegas and nutrition is in step 1, if I'm remembering correctly.
It's in step 1.
I may be wrong.
It is. So you're correct.
To your point, we don't even treat, like, that would be taking moderate to severe patients are probably in late stage step 2 therapy to step 3 and 4. And step 3 and 4 are therapies where we're using amniotic membranes, scleral lenses, long-term steroid drops. So you're getting into this, oral secretagogues, things that most people are not really utilizing in most cases. And so to put those patients, I totally agree, to put the patients with already advanced disease on something that's a step 1 therapy would be also like trying to just solve the problem with warm compresses or artificial tears in terms of our understanding and what we've accepted as a profession, related to, like, okay, well, DEWS is an authority, right? The International Dry Eye Workshop is the authority on dry eye, and they wouldn't even do this. Not even close.
Right.
I just wanted to put a little finer point on that because I think that's a pretty powerful statement that you just made.
And I think the fact that these patients, they were pretty far down the road. There also were some other things that are different than most studies. If you think about trying to figure out the impact of doing one thing, like the Epitropolis study, for example, that looked at dry and found positive results, those patients aren't doing other treatments, and they're not taking lower doses of the same thing you're studying. Whereas in the DREAM study, it included patients, again, all levels with Sjogren's, with RA. They had other inflammatory conditions. Many of them were on oral medications that might have added dryness. Some of them were on steroids. They could actually be on EPA and DHA up to 1,200 milligrams per day on the placebo side, which to me, if we're really trying to sort out one thing as making a difference, I think that complicates it. And then both groups, at least 75% of the participants in both groups over the course of the study had changes in these other therapies like cyclosporin A that could have reduced their cytokines and reduced inflammation. So in terms of being able to extract, despite those facts, we had continued treatment with these other things up to 1,200 milligrams, these other treatments as well. So this additional placebo group who had another year of treatment with these other things had some improvement. Well, that's good. We shouldn't be real surprised about that. The group that got that treatment as well as a therapeutic dose, a higher dose of EPA-DHA, did show improvement as well, and a greater amount. However, there wasn't enough difference between the groups to say that omega-3 made a significant difference. I just think you have these confounding factors within this study that make it nearly impossible to tease out the impact and effect of the omega-3 in this study in this group of patients. But I don't think this should be generalized to say that omega-3s don't work.
Yeah, but
they did work.
It's been that a little bit. Yeah, I think that's the hard part is that, it's sort of in some ways it's it's hard to do a big study like that, and it's expensive.
It is, yeah.
And so to do it again is like this. My thing is I think this is going to become the authority for a lot of people, where they'll just poo-poo it, omega-3s, and it's like, well, we're never going to do a study that big again, or it's going to be a long time. So, all right, well, so I agree with you. I think that establishes the case of why where the DREAM study may have missed in where they were trying to hit. Related to the type of omegas, well, first of all, tell me about the amount, the dose of omegas, and then also the combo of EPA and DHA. Why do I care? What do I need to know about that? Why is one better for one condition and one better for another?
Yeah, that's a great question. I think there's an awful lot of confusion in multiple areas in regard to how should we choose a dosage? I think we would say the majority of patients in the United States have a suboptimal amount of omega-3 in their body. If you look at the works of different studies that have been done, there's a way to determine whether the patient has an ideal amount of omega-3 in their system, and that's called the omega-3 index. We've done that in my practice for several years. We just simply take in states that allow you to pierce the skin, which Indiana does, you can take a drop of blood, put it on a dried blood spot card, and then we send it to a lab, and we get the results back pretty quickly. And we want that. It's a measure of the red blood cell membrane, the percentage of fatty acids that are EPA and DHA. And multiple studies have indicated that number really should be for optimal health. And this is, again, along several lines: systemic health, cardiovascular health, joint, skin, and eye and brain. It should be above 8%. So kind of above 8 to 12%. So patients, we commonly measure that. Patients often report, I ask many patients, are you eating fish? That would be the natural source of these omega-3s, and help us determine the dose they may need. Many patients, when you ask them that, well, they may say yes. Well, how often do you eat it? Well, I probably have, fish, and maybe it's cod, not oily fish. Oh, every couple of weeks, or maybe once a month. Well, that's a very low amount, and you're unlikely to obtain the adequate amount of omega-3 that you need. Omega-3 is part of every cell. We have about 40 trillion cells in our body. Omega-3s are part of the cell membranes of every one of those cells. And within the cells, you have these organelles like mitochondria that are essential, that have membranes. And those membranes have a certain assortment and collection of omega-3s. EPA and DHA, which are the long-chain omega-3s found naturally in oily fish. And when I say oily fish, there are specific fish I recommend my patients eat. And there's an easy way to remember that. It's the SMASH TT. I've added the TT myself. So basically salmon, mackerel, anchovies, sardines, herring, tuna, and trout. So those are
So I could do the first choices. And the last. That's what I would do. First and last. And that's
so within those 7, hopefully you'll find 1 or 2 at least that you like. So those should be part of your diet. Oftentimes they're not. One recent study showed that in general, the only patients who through their diet and supplementation will achieve above 8% are those who have fish, oily fish, 3 times per week, and who also supplement. Those are the people in your chair likely to hit the 8%. When I do this test, I almost universally find patients are under where they should be in those omega-3s. So when I find that, I do, several things in looking at, let's say, a dry eye patient. I'll press on their glands. I want to see the quality of the oil. There's research that shows several mechanisms likely at play where omega-3s are beneficial for patients with dry eye disease. And one of those is improving the quality of the meibum. We actually have a study where they harvested oil from the glands. This was an 8-week study using an omega-3. Some of the earlier studies with lower amounts of omega-3 were not successful. But when we got above 2 grams per day, that's kind of a key, I think, in a diagnosis for patients not eating fish, typically falling under where they should be with their omega-3 through diet. Around 2 grams a day seems like a very reasonable dose to start. But they found patients who took...
Sorry, after that 2 gram a day, we can get back to that. But how long of a duration before I would expect to see a clinical benefit?
In this study, looking at the quality, it was about a 2-month study, and harvesting before and after, they actually found 5 times more omega-3. It's a small percent in the meibum. The oil has lots of different fats, and omega-3s are a fairly small percent, but they found a significant improvement, 5 times more. And interestingly, when they harvested, because we hear a lot about EPA versus DHA, the supplement they took had both, but what they actually found increased. They had, in 14 patients in this one study, there was no DHA or EPA found. After 2 months, they found 14 out of 14 patients who they could identify DHA. So EPA is known for its ability to reduce inflammation. It's a strong anti-inflammatory, and I love it. I think it has great benefits. I think, however, we overlook the value of DHA. And DHA is what was actually found in the meibum. And then there are other studies that help us understand that it's not just EPA, or not necessarily EPA should be predominant. If you look at the tuna fish study done back in 2005, which was the first study we looked at that found some association between eating fish and reducing risk of dry eye. It was a study of over 30,000 women that were monitored over time. They didn't have dry eye diagnosis at baseline. And 4 years later, as they were followed, they had a certain percentage, numbers of those, a certain percentage of those who did have dry eye disease. And they found there was an association between the amount of tuna fish they ate and their likelihood of diagnosis. So if they had, let's say, 0 to 1 servings per week versus like at least 5, which is a lot of tuna fish, I do admit.
Way too much.
But
yeah, like 1 is too much.
That was a lot of tuna fish. But those who had 5 to 6 or more per week, they had a 68% lower likelihood of a diagnosis of dry eye at 4 years, which is interesting. It's an association. But what's in tuna fish? The majority of omega-3 in tuna fish, it's about 70% DHA and about 30% EPA. So there again, they did a separate analysis.
I don't know the answer to this. Is there any ability for our body to convert one to the other? Is that conversion process occur or doesn't?
That's a great question. There's very little ability of the body to produce. So there used to be a thought years ago that there was this retro conversion between EPA and DHA. Really, that's not true. And even if you eat, like, one of the fallacies people say, well, I don't like fish, I'll just eat walnuts because they have omega-3, right? Well, they do, but it's ALA. It's a shorter chain. And our ability metabolically to convert that to a longer chain omega-3 is very low. So you're simply not going to get enough EPA and DHA in your body without actually having some direct dietary intake of it or a targeted supplement. So yes, it's important to supplement.
Or does triglyceride or ethyl ester forms have an impact, or is it just a argument that companies that have one will make against the other?
That's a good question. I think there's definitely research, and the best science shows that the ethyl ester, which is not found naturally in nature, has an ethanol backbone, simply does not get digested as readily. So the figures I see, you can still get benefits and raise your omega-3 index if you take enough of the ethyl ester form, but you have to take a higher amount. And on an empty stomach, the amount of food in your stomach is very critical if you take the ethyl ester form. If you take it on an empty stomach, you're probably only going to get about 20% absorption. So maybe you took 1,000 milligrams and you get a benefit of 200. Whereas with the triglyceride form, the body digests it more efficiently, and you basically get it all. And eating with food is probably a little bit beneficial even with triglyceride, but generally it's not nearly as critical. So I think if you want to reduce potentially the digestive issues, there really aren't any side effects to omega-3. If you think about something we can give patients that is natural, safe, effective, ready available, pretty inexpensive compared to many drugs, if you will. Omega-3s have some real benefits and advantages in those areas as well.
Let's pick that apart a little bit, just because, there are some people that will worry, well, I can give this to anybody. What about patients on blood thinners? Or what about patients with kind of finicky thyroids? Do I have to worry about that at all?
You really do not. Omega-3s are extremely safe. There's no concern about patients with thyroid disease. There's no concern about patients with diabetes. If anything, it's beneficial for those patients, and many of them are going to be low in omega-3s that are so important for their retinal health. So I think even in terms of blood thinner, yes, there is a platelet effect of omega-3s that can prolong bleeding times a little bit. But when you actually look at the research, there was a study I looked at, Norwegian research. They studied patients up to 6.9 grams a day. And they found no adverse outcomes. Although it may affect the impact a little bit of how long it takes the blood to clot, it's not associated with any poor outcomes, even in patients who are on blood thinners, in surgical patients. So I've heard the argument made that maybe, we have these normals that we take from a cross-section of a large number of people. And if those patients are undernourished with omega-3s, maybe our scale's wrong. Maybe what we really should be saying is it's normal. Maybe the amounts that we find, the numbers we find when patients have appropriate levels of omega-3, maybe those are really the normal numbers, and we just have skewed the data. So I think there's really no concern now. If you go in for surgery, your physician's likely to tell you to go off your omega-3. And I don't argue with that. I don't tell my patients to ignore that, but it's really not a concern. And if you think about it, the blood tissue levels within your body with omega-3, they go up and down very slowly. So even if you go off your omega-3 for a week or two, the amount in your tissues has hardly changed. So it's really kind of a moot point, even with that. But it's really not a concern. They're very safe. Yes,
it makes the surgeon feel better. Yeah,
it does.
So then, let me. So we'll talk. I want to get a little bit into the details of dry eye in your practice. So,
okay,
I come in and let's take two scenarios. One scenario is I have no symptoms. Are you gonna evaluate me differently than if I have symptoms? Comprehensive exam, dry eye. Mm-hmm. Is there something that you're going to do every single time to screen for me, or you're just going to wait until my symptoms develop?
Yeah, I'm definitely going to look at each patient. Many patients who've had dry eye long enough will be symptomatic over time, but there's such a range of patients with and without symptoms with dry eye disease. If you think about it, even in advanced stages, as dry eye disease advances, sometimes it affects the ability of the corneal nerves to sense discomfort. So if you're only going to treat patients who hurt, I think you're really missing the boat. And Agreed. If you look carefully, look at the patient's meibomian glands. If you take a moment to put a little bit of fluorescein dye in the eye, you can easily detect staining on the cornea. Oftentimes it shows up first on the bulbar conjunctiva nasally. You can take your thumb and you can press to determine whether the glands along the lid margin with those meibomian glands are secreting oil. If you do a little more formal evaluation, you can take something called the lid stick, which I like. It's the Oculus lid stick, and just express those glands, and you can pretty easily see what kind of quality oil's inside those glands. If the patient doesn't have symptoms, but they have signs of meibomian gland problems structurally, if I see surface irritation, I see glands that are blocked, maybe I see a frothy tear film. One of the things that meibum that comes out of your glands is designed to do is kill bacteria. And so when you have a lack of meibum, it gives opportunity for bacteria to overgrow. You have an overgrowth of bacteria on the lid margin interacting with the oils and creating this frothy tear film. So there are just so many things we can see in sometimes patients who do not have symptoms that should be addressed. So I'm going to bring that up to you. I may do a real brief video just to show you what I see in some cases, but I'll tell you that there's an issue that's progressive, inflammatory, likely to persist or get worse, even in the absence of symptoms. And I would recommend you come back in for a medical evaluation so we could look at it more deeply, more closely. I'll do a number of tests, and then we'll come up with some treatment. And pretty much 100% of the patients in my practice, I'm going to talk to them at that visit, the next visit when they come in, about omega-3s. And if
you do nothing, so you wouldn't do anything at that comprehensive exam other than educate the patient. You're identifying. So I love this because you're thinking on this. When I talk to people who are operating at a really high level within their practice related to ocular disease management, they almost all, and they do primary care. They almost always do it the way you do it. They look at that comprehensive exam, and this is you've heard me talk about the total patient care model. You've heard me talk about what does a comprehensive exam do, but they look at their comprehensive exam and they don't look at it like, well, this is just routine, or this is just like I'm just going to do this. They actually look at it as like, and because I think people think that, like, some people, if they don't do these things, they're like, well, I'm just going to do the same exam for every single patient, and I'm going to do a really great exam for every single patient. But what they wind up doing is they wind up ignoring the stuff that can be a big issue over time for patients, and probably already is a big issue for them. But unless that patient is spewing it out of their mouth, they're going to ignore it. And so they're saying, well, I'm just going to do the same comprehensive exam no matter who's coming into the office, but people that do it really well are, yes, they're going to take the complaints, but they're going to look systematically for the things that they know are going to be causing that patient problems over time. It's no different than when we evaluate a patient for macular degeneration or glaucoma or cataracts.
Right.
And dry eye is just one of those other things. And so what I'm hearing from you is you look to identify, to find a problem, then educate the patient, kind of give them a reason of why it's important that you're digging deeper, and then have them back at another visit to dig deeper. Almost everybody that does this at a really high level, that does primary care, does it exactly the way you described. It's really interesting to me. The most common questions I get include, what ophthalmological codes or evaluation and management codes should I use? What ICD-10 codes do I need to bill with this CPT code? What CPT codes can be billed together and what can't? And my favorite, how do I manage a patient who has diabetes who comes in for a quote-unquote routine eye exam? These questions really highlight the confusion and uncertainty that serves as a daunting hurdle for providers, makes it more challenging for them to care for their patients and provide those patients with the best opportunity for a lifetime of ocular health and clear vision. That's why we built iCode Education, for this specific purpose. Our mission is to provide optometrists with resources to help you understand disease states, revenue cycles, and billing and coding so that you can put that on autopilot and truly care for your patients. Check out iCodeEducation.com. That's EYECODE education.com. We've developed a premier billing and coding bundle that includes all of our billing and coding resources in one place. We also have a 10% discount code just for listeners of this podcast. Enter the coupon code EYECODEMEDIA22 at checkout. We'd love to work with you. Check out iCodeEducation.com. One of the challenging things with patients is that when they invest in a really high quality pair of glasses and customized lenses, occasionally it can be difficult to keep those lenses clean, scratch-free, and smudge-free. Now, we have the ability with Crizal Sapphire HR lenses to offer our patients a best-in-class anti-reflective coating that is also resistant to scratches, smudges, and deposits. This means that patients spend more time enjoying clear and comfortable vision and less time caring for their lenses. So remember that you can provide patients with the best in quality, best in class, transparency, clarity, durability, and UV protection in a single Crizal coating. If you want to learn more about Crizal Sapphire HR, contact your Essilor account executive or visit essilorpro.com/Crizal.
I think, we're doing that routine exam. Maybe they have, vision insurance, that kind of thing. We have a limited time as well. And, we have to be efficient so we can identify those things efficiently, explain to the patient why they need additional care, have them come back typically under medical, explain this is a medical condition. We're going to do testing that will be submitted to medical insurance based on what I'm seeing here today, subject to copays and deductibles. I always like to say that so they have an understanding of what's involved. And then you do those tests. And then once you've done your diagnostic tests, you've identified the level of dry eye disease. Again, level 1, if they have anything at all, level 1 treatment is going to be omega-3. So if they're not already on omega-3 at an appropriate level, and I think in the right amount of it, then I'm going to talk to them about that as one of their basic things that we're going to start at that next treatment visit.
Well, that's what I want you. That's what I want to talk to you about. Is that so? Okay, I come back. What when I come back for that battery of tests, you're gonna. So my assumption is, and you could tell me if I'm wrong. Well, no, just tell me what's the battery of things you're going to do to assess, and then what's going to determine whether or not you're going to place me on an omega-3.
Sure. So we'll do a number of tests at that next visit. We have patients not put or instill any drops if they're on an artificial tear, nothing in the eyes 2 hours before they come. I want to measure tear osmolarity. I think that is key. It helps us understand the homeostasis of the tear film. We have these layers of tear film. If there's a lack of oil, if there's rapid evaporation, if there's thinning of the tear film, that osmolarity number is likely going to be high. We'll look for P9s to see if there are signs of inflammation in the tear film. I'm going to look carefully by putting dye in their eye at the corneal surface. I'll measure tear breakup time, look at corneal staining. I'll look at tear prism height to determine whether I feel the patient has aqueous deficiency as well. I'm going to look carefully at the meibomium glands, and I will normally take my lid stick and express at least the central 5 along each lower lid, so 10 glands, and I'll assign a number to the oil. If I see toothpaste, if I get no oil, that's a 0. If I see toothpaste, it's a 1. If I see, butter, creamy, gel, it's a 2. And if I see really good oil, it's 3. And I'll get
and
a
how
number.
Often do you see really good oil?
Not too often.
Yeah,
In
I
fact,
know. I'm astonished
it's
when I do. I'm like taken aback when I do.
Yeah. So those patients, I'm going to identify their level based on those things. We'll discuss the results of those findings. And I'm going to start them on, again, assuming they're doing nothing right now, I'll put them on omega-3s. I'll have them do some kind of a warm compress typically. I'll do an artificial tear, and oftentimes, hypochlorous acid or a spray or a cleanser. So those are like the very basic things. Let's say they have low symptoms and maybe early signs. And then we'll have them come back in a few weeks. We'll do a follow-up visit. If we start to see some improvement in the way the eye looks, feels, the glands, how they're producing oil, great. We may continue with that. If we find patients with more severity, we may have something where we'll recommend a special procedure like IPL. So we look carefully at the lid margin for signs of telangiectasia, and I think IPL just helps everything else we do work better.
When you think about, so you mentioned the omega index, but you didn't mention that you're doing it at that initial visit. Are you waiting until a follow-up visit to use the omega index?
I would say I would typically bring it up. So at that first visit, if the patient says, well, I'm already taking omega-3 or there's some resistance to it, but I commonly would recommend it at that first visit, quite honestly.
Okay.
So I'll say, yes, we don't know for sure your level. Some patients will do better and be more compliant if they actually have a number. So I would say I could start you on this omega-3. Some patients will say, well, maybe I'll just see what my number is if they're not convinced. Not everybody's open to taking omega-3s up front. And especially in those patients, if you have a number and you say, well, we want that number to be above 8%, and then the test comes back and they're 4%, it's pretty easy to improve their compliance by explaining what that means, and that we really need those levels higher. So, and then as we do the testing, the patient takes a supplement, and it takes around 3 to 4 months with the lifespan of the red blood cell to stabilize and maximize. Let's say we've given them 2 grams a day roughly of omega-3. Then we'll measure that again, and then we can see how we, are we compliant? Have we gotten the right dose? I always recommend they eat fish as well. So depending on how much fish they eat will help determine the amount I give them. I like to recommend a balanced formula that has both EPA and DHA. If you look again at most oily fish, they have a balanced amount or more DHA. So I think if we're trying to mimic nature and try to provide a holistic approach again, we can give a supplement that has pretty much even amounts, a balanced amount between EPA and DHA, and they're both beneficial for dry eye.
Talk about the billing process for the omega index. Talk about that. That's going to be a holdup for a number of doctors.
Mm-hmm. Yeah. So the test is over the counter, if you will. So patients could go online if they choose and do it themselves. The test online that we use is just omegaquant.com is where we go. Last time I checked, it was $49.95 to do the test. We do it for them in the office. We charge $50. So I tell them we charge them a nickel to do it for them. I don't really get a lot of resistance with that. If patients understand the value of it, it does help us verify their need and help us understand how much they need. And I tell patients too, if you want to swallow less pills, eat more fish, oily fish, and some patients are more open to doing both. But I don't really get a lot of resistance. It's simply a drop of blood again on a dry blood spot card. I have my staff do it. It doesn't take long. We get those results back within a couple weeks, and then we can have that discussion.
I like it also because there's this, there's in a number of patients when I talk to omega-3s, generally I'll tell a patient, like, I'm agnostic. If it does what it needs to do, I'm agnostic to the brand. But what I am not agnostic to is taking a brand that they're getting filler omegas or something that just because they can get it so inexpensively. And that's okay. Great if it does what I want it to do. I really don't care. But at the same time, what I do care about is if I get no clinical benefit from it, and the patient gets no symptomatic benefit from it, and it's just garbage that they've sold you for a whole bunch less. At least that tells me, like, that in those instances, it can show me, like, look, you're supposed to. I want an 8%, and you're at 4%, and you're telling me you're taking exactly what you're supposed to be taking. So what are you taking? And then that kind of stimulates additional conversation as opposed to being like, well, was it the omega-3? And now I'm sitting here trying to convince them of a different brand because I know that brand works, as opposed to just relying on the evidence of what you're seeing clinically. And if it's working great, then you could be like, wonderful, keep using this exact same one, and make sure that when we check it that if they're switching or swapping components and it doesn't continue to work, then we need to fix that. But at least you can know and have the conversation. It's better evidence to have a conversation with on those things.
I think a lot of patients who are taking omega-3s, particular brands, some of them aren't taking. They've tried it before and they'll say, "Oh, I burped that up. They have these unpleasant sensory experiences." That probably happens in about 20% of patients. So having a high quality triglyceride formula, they don't need to swallow as many pills. They're getting a more therapeutic dose. They're less likely to have these side effects. And we provide that in our practice as an option. They can, buy it any place they want. But we provide and have a specific recommendation of this particular one that we have had really good success with. And sometimes it's actually very competitive price-wise because they don't need as many. And if you can find something they tolerate well, because if they take some product and, they burp it up and they have these issues, they're not going to continue doing that long term. So finding a very high-quality product that they digest easily, is very competitively priced and convenient for them to purchase right at our practice. We do that commonly, and that has worked very well for us.
Tell me about, this is kind of the last thing because we mentioned it, but I want to be respectful of your time. Let's transition from ocular surface disease to maybe retinal conditions, and maybe just so we can look at the evidence. Talk about AMD, and actually, you know what? Let's not talk about AMD. You mentioned diabetes. I think that's probably something that more people are thinking less about. And so what's your thoughts on how omega-3s work and how they benefit patients who have diabetes?
Yeah, so the retina contains, as the number one fatty acid, long-chain fatty acid, there's a lot of DHA in the retina and in the brain. And if you're patients who have diabetes, again, commonly have low levels of omega-3, just as other Americans and other patients do. So for optimal retinal function, I think having a good source of omega-3 in your body through your food is important. Again, I use that same criteria. So I do the omega-3 index for those patients, and I tell them I want them above 8%. So their body has the building materials necessary for a multitude of reasons, including their retinal health. We need more research in diabetes. There is a study showing that as part of the PredMed study that was looking at diet in terms of cardiovascular health, we found, I think, over 5,500 patients that were diabetic type 2, men and women, followed for 6 years. If they had at least 500 milligrams of EPA DHA in their diet daily, they had about a 50% less likelihood of developing sight-threatening retinopathy. So advanced stages of retinopathy requiring surgery, laser, that kind of thing. So we have some evidence that omega-3s can help reduce, but I just think purely from the clinical standpoint, from the scientific standpoint, knowing what omega-3s, how important they are to retinal health, I think for our diabetic patients to have omega-3s is an important discussion, and the omega-3 index gives us a guide as far as how much we should be prescribing once again.
Even just from a standpoint of the effects, and I guess I'll let you comment on this too, but we know that patients, it's pretty standard to lower cholesterol in patients who have diabetes as well now. It's a pretty well accepted kind of second line or second, if you're addressing the diabetes, most internal medicine or family medicine physicians are going to address cholesterol as well to try to get tighter control for the same reasons. So, even in that sense, the cholesterol lowering capacity of an omega-3 should benefit even outside of the neural tissue concentration of DHAs.
Yeah.
What do you think about that? What's the cholesterol lowering benefit of an omega-3?
So I think if you look at the best research we have, there's been some different thoughts over the years. As far as LDL cholesterol, the omega-3 is typically fairly neutral in that. What it does, however, is it helps elevate HDL, which is very important for vascular health. It helps improve blood flow, probably oxygenation. There's something called red blood cell distribution width. So your red blood cells have to basically deform about half of their diameter to squeeze through the capillaries. And omega-3s appear to help the flexibility of those red blood cells, getting through to provide more oxygen. I think that's important. There's also really strong evidence that at a proper dose, omega-3s lower triglycerides. And I think that's a really important factor as well. So you can do multiple things to the vascular health of the tissue. There's also evidence that omega-3s lower blood pressure. And many patients who have diabetes also have elevated blood pressure. So if we can reduce blood pressure, if we can improve oxygen and blood flow, lower triglycerides, I think we can have these additional vascular benefits for our diabetic patients, which are so key. And they're also at risk for cardiovascular disease to a greater degree than patients who don't have diabetes. So one of the reasons I recommend omega-3s for my diabetic patients is, again, if you get above 8% as one example versus the typical 4% in the United States, you're actually, there was a meta-analysis of, I think, 27,000 patients in 10 studies. You're reducing the risk of sudden fatal heart attack by approximately 35% when you get above 8% in their omega-3. And given the fact that cardiovascular disease is so pervasive among diabetic patients, I think you're making positive impacts on their general health and their heart health that go even beyond what you're seeing in benefits you're going to get within the eye. And also, as we know, many patients with diabetes, a high percentage of them have dry eyes. So another reason for them to be on omega-3. So you're just getting multiple benefits, holistic benefits. There's just so many things with omega-3s that are beneficial, and we could talk through a list of additional things from cardiovascular to autoimmune diseases to joint health and all those things that we're doing something good for our patient holistically when we're recommending omega. Even if we're focusing on dry eye disease, we are doing something positive for the general health of those patients who really are not. And again, most Americans are just really under where they should be in omega-3 levels in their blood, in their body tissues.
I think that's a great way to stop it. I think this is a pleasure. I've thought through a few things differently than since our conversation, so thank you for that. Dr. Roark, where can people find you if they want to reach out and contact you?
Sure. I would be happy. My email address is Mark Roark, just MARKROARK.OD @gmail.com, and I'm happy to field any questions to discuss. There was some additional information I'd like to talk to you sometime about macular degeneration, because I think there is a lot of misconception of how omega-3s, what they do, and their benefits. We have 3 RCTs in macular degeneration. I think there's some discussion, something worthy to discuss in that might clear up some confusion, because I think just within this whole realm of how omega-3s work and what they do, there's just a lot of confusion, quite honestly.
So I think that's why I diverted from it, because I think it's a longer conversation. I think maybe we plan for that in April or May. How about that?
Okay, that'd be great. I'd love to talk about it.
A good plan. All right, let's do it. So
sounds great.
So, Dr. Roark, thanks for coming on. I really appreciate it.
Thank you. Thanks for
the invite. And I look forward to our next conversation. Yes, you're welcome.
Sounds wonderful. Thank you, Chris. Take care.
You're welcome.